In early breast cancer, one of the most important questions is whether the cancer has spread to the axillary lymph nodes. That decision affects staging, treatment, and long-term outcomes. Today, the standard way to check this is Sentinel Lymph Node Biopsy, or SLNB. It's less invasive than full lymph node removal, but it still requires surgery and can lead to complications like pain, infection, and lymphedema. So the core motivation here is simple. If we could reliably predict that lymph nodes are not involved, we could spare some patients an unnecessary procedure. This presentation looks at whether we can do that using information available before surgery. For each patient, there are two main sources of data. First, whole slide images from a core needle biopsy of the primary tumor. Second, clinical data, such as age, tumor size, and biomarker status, like HER2. The prediction task is binary. Does this patient have axillary lymph node metastasis or not? Whole slide images are extremely large, so the model never sees the entire slide at once. Instead, pathologists first annotate tumor regions, and those regions are divided into many non-overlapping patches. Each patch is passed through a feature extractor, which turns tissue patterns into numerical features. Those patch-level features then have to be combined into a single patient-level image representation. The key idea explored here is multimodal fusion, meaning we combine image information and clinical information. The question is when to combine them. Early fusion means image features and clinical features are merged before the final classifier, so the model can learn interactions between them. Late fusion means you train an image-only model and a clinical-only model separately, and then combine their predictions at the end. A helpful way to think about it is that early fusion combines evidence, while late fusion combines opinions. The study focuses primarily on early fusion. Image features are extracted using 4 models, VGG16_BN as a conventional baseline, and 3 more recent foundation-style models, QUILT-1M, PLIP, and BiomedCLIP. After feature extraction, there are 2 main ways to process patches. One is PCA, which reduces dimensionality and noise. The other is a learned weighting using a fully connected layer, which allows the model to emphasize more informative patches instead of treating all patches equally. These processed image features are then concatenated with standardized clinical features and fed into a classifier. For comparison, they also test early fusion without any feature processing, where patch features are simply averaged, and they test late fusion, where image and clinical models produce separate probabilities that are combined afterward. All experiments are run on the BCNB dataset, which includes biopsy whole slide images and clinical data from 1,058 patients. There are 655 patients without lymph node metastasis and 403 with metastasis. The data is split into training, validation, and test sets. Because there are more negative cases than positive ones, this class imbalance already hints that models may lean toward higher specificity. When looking at results, a consistent pattern emerges. Across almost all setups, specificity is high, often above 0.7. That means the models are good at correctly identifying patients who do not have lymph node metastasis, which is exactly what you want if the goal is to reduce unnecessary SLNB. However, sensitivity is noticeably lower. The models struggle more to catch all true metastatic cases, which is a critical limitation. Single modality results show that the clinical-only model has the highest specificity, but performs poorly on other metrics. Image-only models improve when using features from foundation models compared to VGG16, which matches what we see in other pathology tasks. Early fusion generally performs best overall. It outperforms both single-modality models and late fusion models across most metrics. One standout result is that PCA-reduced dense features from VGG16_BN combined with clinical data achieve the best overall performance. Importantly, early fusion improves many metrics, but sensitivity increases only slightly, showing that detecting metastasis remains the hardest problem. Late fusion tells a different story. It often pushes specificity even higher, but at the cost of sensitivity. One late fusion configuration reaches a specificity of 0.91, meaning very few false positives. That could be valuable in settings where minimizing unnecessary procedures is the top priority, but the trade-off is a higher risk of false negatives. There are also clear limitations. Non-overlapping patches can lose information at boundaries, and averaging patch features assumes every patch is equally informative, which is rarely true in pathology. Subtle metastatic signals may be diluted when everything is pulled together. The main takeaway is that multimodal early fusion improves prediction of axillary lymph node status and shows real promise as a rule-out tool. High specificity and negative predictive value mean these models could help avoid unnecessary SLNB in selected patients, but lower sensitivity limits their use for confidently detecting metastasis. Improving sensitivity through better patch aggregation and smarter fusion strategies is the key challenge moving forward.